Good afternoon, everybody, and welcome back to Grand Rounds. Today, it's my pleasure to introduce Dr. Sonam Patel. Dr. Patel is a hematologist, oncologist. She joined McFarland Clinic and became a member of the medical staff at MGMC in 2021. It's greatly through the efforts of Dr. Patel and her colleagues in medical and radiation oncology, general surgery, pathology, and radiology that Bliss Cancer Center has been designated as an accredited breast cancer center by the National Accreditation Program for Breast Centers. And the CME committee is very appreciative of the fact that she has kindly accepted our invitation today to provide us with an update in local and metastatic breast cancer. And please join me in welcoming Dr. Patel.
Thank you, everyone, for taking the time to be here. Just to briefly review our objectives, they're pretty straightforward. I just really wanted to talk about the updates in the treatment of local breast cancer, so stage 1 through 3. In the last year or so is where I'm going to focus our attention, but also the advances in the last year in treating metastatic breast cancer as well. And then briefly at the end, we're going to talk a little bit about the future directions of breast cancer care and where I think things are going to be headed over time. So we'll start our talk off with just early stage breast cancer. So this is what we see most commonly because of screening mammograms. So this includes stage 1 to 3 breast cancer located either in just the breast or in the axilla as well. And before we delve into the updates, I wanted to make sure we had a little bit of a foundation here. So the principles of managing local breast cancer is where we're going to start. And it starts pretty simply with diagnosis, and that typically is happening with mammograms for most women. And if there's an abnormality, we're seeing radiology recommend spot compression views and ultrasound to further characterize these lesions and to also provide, size and any more information it might about the axilla if there's anything else involved. And then after it's been characterized by imaging, we tend to move on to biopsy with clip placement in the primary tumor. And then if there are abnormal lymph nodes, if it's just one, they'll typically be biopsied with a clip. But if there's multiple, then typically one is sampled to confirm that there is lymph node involvement. I wrote consider MRI breast, and a lot of this is based upon breast density. So if someone is coming in with a diagnosis of breast cancer and has category C density breast or D density breasts, then I do think it's a really good idea to get an MRI, and it's something that we will often order once they come to see us. And the reasoning behind this is, one, to make sure we're getting a clear picture of the area that's involved. And then 2, to help make sure there's no other lesions anywhere else that we need to be aware of before we formulate their plan, put them through surgery. The only really exception to being able to skip an MRI breast in higher density breasts would be someone who's already made the decision to get bilateral mastectomies, and it wouldn't really necessarily change their management. But generally, in all other situations, if we've got a new breast cancer or DCIS and they have dense breasts, then I think it is definitely worth it to do that imaging. And then further staging imaging with like PET scans or CT scans or bone scans is really just based on clinical judgment when they come to see us. If there's new concerning symptoms or if something pops up on labs that's worrisome, we can consider doing further imaging. But these are not routinely done, especially in low stage breast cancers. Surgery is often the next step, although sometimes, especially nowadays with more advanced breast cancers, we are using neoadjuvant therapy more and more. And then radiation therapy, which typically and very broadly is used in patients who've had a lumpectomy or positive lymph nodes or margins, although that's a very broad generalization there. But that's the kind of general formula that we're looking at with managing local breast cancer. In terms of surgical management, there's really 2 sort of decisions that are made. And the first one is whether or not to do a lumpectomy or a mastectomy. And fortunately, because mammograms are able to pick up breast cancer quite early, most women are able to make a choice between lumpectomy or mastectomy for themselves, just based on what they prefer. But that being said, there are certain situations where a mastectomy might be preferred, and that could be in patients who have smaller breast sizes and larger tumors, or where there's more invasive disease, or if there are genetics involved or a family history involved that might suggest they have a high likelihood of developing another breast cancer as well. In terms of axillary management, again, for the vast majority of women who are getting detected early, a sentinel lymph node excision is predominantly what they need, and that is the standard of care for all invasive cancers. But where the waters get a little bit muddy and a little bit gray is with your axillary lymph node dissections. So I sort of just gave very broad general terms here, but I'm going to do my best to sort of explain what the recommendations are. And so essentially, if there are 1 to 3 lymph nodes that are positive at the time of surgery, then we can often get away without a full dissection. But any situation that has greater than 3 lymph nodes involved at the time of surgery means that that patient is going to need an axillary dissection. There are very specific situations where sometimes this can be admitted, and one such situation I sort of mentioned here is if you have 1 to 3 positive lymph nodes and then that patient gets neoadjuvant treatment and then they become N0, meaning they sample a sentinel lymph node at the time of surgery and there is no disease in that lymph node, you can consider omitting an axillary dissection. But again, this enters a really big gray zone where a lot of the upcoming research that we're going to talk about is trying to answer. The one thing that is noted is that clipped nodes, so those nodes that we might have biopsied at the beginning, should always be removed if possible. Basically, the recommendation is every attempt should be made to remove a clipped lymph node if feasible. So as I alluded to, axillary management after neoadjuvant treatment is really where things are getting very foggy, and included in that is radiation. I'm just going to talk briefly about this subject, but there's just a couple interesting trials that were presented within the last year, and one of them was this top one at the San Antonio Breast Conference, and it's a retrospective study, but it was a good study that looked at patients who were basically of patients who had an axillary lymph node post neoadjuvant chemotherapy and were found to have isolated tumor cells. So I mentioned earlier that patients who have neoadjuvant chemotherapy and then are sentinel lymph node negative don't require full dissection. So these are patients who had isolated tumor cells, not macroscopic disease on the axilla. And they found that the chance of recurrence in the underarm was about 4.5% in those with no dissection versus 4.1% in a group with dissection. So really not much difference. So maybe this is another subset of patients who could be spared a full dissection of their underarm. Again, this was just a small retrospective study. To answer this question, I think fully, we're going to need a more prospective evaluation of this, but this is a good starting point. This bottom trial is just an interesting upcoming trial, which is going to take a look at axillary lymph node dissection versus axillary radiation in N1 patients. So again, N1 means 1 to 3 positive lymph nodes in patients with ongoing positive nodes post neoadjuvant chemotherapy. And so what that means is they got chemotherapy, had positive nodes before that, and still have positive nodes after. Right now, what we are doing is being very aggressive and doing axillary dissections in those patients because they're felt to have a more aggressive disease that's chemo-resistant. But this trial is aiming to look at, well, can we spare them a dissection and just do radiation? So those will be interesting results to have in the future. Very briefly, I'm going to talk about radiation here. And one of the interesting San Antonio Breast Conference trials that was presented was this NSAB and RTOG trial, which took a look at omission of nodal radiation therapy after pathologically proven lymph node involvement that went to pathologically proven no lymph node involvement. So they had 1 to 3 lymph nodes that were biopsied in the beginning and then got neoadjuvant treatment and then had 0 lymph nodes. And they found that invasive relapse-free survival at 5 years was about 92% in patients with no radiation and 92.7% in patients with radiation. And they both had the same distance recurrence-free survival at 5 years of about 93.4%. So overall, it favors omitting nodal radiation in patients with a pathologic complete response in those who had just N1 disease, so just 1 to 3 positive nodes. Those with N2 to 3, so multiple nodes involved, or matted nodes or more invasive nodes should still be receiving aggressive axillary management with radiation and axillary dissection. So then we're going to move on to systemic therapy for the rest of our talk. But the first section is going to be on systemic therapy for local breast cancer. So neoadjuvant treatment before surgery, adjuvant therapy after, and then also including adjuvant endocrine therapy as well. And just to kind of give us all a reminder where the world of neoadjuvant therapy is right now. And essentially, on the left over here are the NCCN guidelines of people who are candidates for preoperative systemic therapy. So definitely patients who have inoperable breast cancer. So for whatever reason, if it can't be excised because it might be T4 and invading into areas, or they might have bulky lymph nodes that are fixed or matted down, or those with inflammatory breast cancer, which is what the IBC stands for. Those patients are absolutely going to get neoadjuvant therapy because it is unlikely that surgery alone is going to be able to take out all of the tumor. The second group of patients is what I will say most people fall into, is that operable breast cancer patients who are in the HER2 positive disease state or triple negative disease with slightly larger tumors or lymph node involvement. These are patients that we often are just recommending upfront neoadjuvant treatment for a couple reasons. One being that they often will see a complete response at surgery, so can potentially minimize surgery. But the second reason being is that they're likely going to need chemotherapy or neoadjuvant treatment anyway, so we're just moving it to the upfront situation. Another one to draw our attention to is that you can use this in large primary tumors relative to breast size. So women who have larger tumors and smaller breasts who want breast conservation therapy could use neoadjuvant treatment as a way to shrink it and proceed with a lumpectomy instead of a mastectomy in certain situations. On the right, I've sort of listed in very broad terms again what systemic therapy options there are for these patients. And generally in triple negative breast cancers, we are using a regimen of chemotherapy plus immunotherapy. And in HER2 positive breast cancer patients, we are using chemotherapy plus HER2 targeted therapy. And then this last category is interesting, the estrogen receptor positive breast cancer patients. We aren't typically doing neoadjuvant treatment in these patients. Really, with the exception of people that have inoperable disease or patients who desire conversion therapy, meaning those women that have larger tumors that want to shrink it down before surgery. And the reason we don't typically do it is we don't see a lot of complete responses in this situation. And a lot of these diseases are very slow growing and so don't respond to chemo incredibly well. But if we are in a situation where you have to use it, then it would just be chemotherapy right now as the standard of care for managing that. So that kind of brings us to this next slide over here, which is a couple of recent studies that are taking a look at neoadjuvant immunotherapy in estrogen receptor positive breast cancer. So we know that we use it a lot in triple negative breast cancer, but can we use it in a slightly different patient population, and what kind of benefits do we see? So the two trials we looked at are the Keynote 756 study, which was presented at ESMO last year, and this took a look at high-risk estrogen receptor positive breast cancer patients, so those with larger tumors or lymph node involvement who had grade 3 disease. So these are patients that have a higher chance of relapse, and they treated them with neoadjuvant chemotherapy plus immunotherapy, and in this situation they used pembrolizumab. Whenever we see Keynote trial, it's often pembrolizumab. It is always pembrolizumab based. And what we have here is the pathologic complete response. So when they went to surgery and took them out, 24% of them had no residual disease, which is pretty good compared to 15.6% with chemotherapy alone. So that's certainly a benefit. It's not quite as good as what we see with people who have HER2 positive breast cancer or triple negative breast cancer, but it is certainly better than what we have. The Checkmate 7FL study was also presented at ESMO and showed very similar results. So they had high-risk estrogen receptor positive breast cancer patients who, again, had larger tumors or with lymph node involvement. They also included some grade 2 patients who had low expression of estrogen receptor. And so They put those patients on a combination of chemotherapy and nivolumab. So nivolumab is what was used in all CheckMate trials. And they showed a pathologic complete response rate of 24.5%, so very comparable to the previous study in the combination arm versus 13.8% in the chemotherapy-only arm. So this is promising and maybe something we could use in the future for estrogen receptor-positive breast cancer patients. As with all immunotherapy in cancer in general, the question remains as to who is actually going to benefit the most. I think if someone could answer that question, that would really change how we use immunotherapy. And a lot of research in oncology is geared towards answering that question. So this trial did do some subgroup analysis where they took a look at patients with higher CPS scores and more tumor infiltrating lymphocytes, and those patients tended to have a better response. So this is probably where they're going to gear some of the research to. But summative comments on this, it's a fairly preliminary study right now that looks at just pathologic complete response. I think before we really adopt this into use, we want to make sure that there's a progression-free survival at the very least, and ideally we want to look at overall survival benefit as well. Moving on to adjuvant therapy for estrogen receptor-positive breast cancer patients. Most of these patients are just on adjuvant endocrine therapy with the standard of care tamoxifen for premenopausal women and aromatase inhibitors such as anastrozole or letrozole for postmenopausal women. And in some younger, high-risk premenopausal women, we can consider ovarian function suppression or oophorectomies to induce menopause as well. In the last couple years, there's been a little bit of a shift in terms of using something such as abemaciclib in high-risk women. So these would be women who had greater than 4 lymph nodes involved at the time of surgery or 1 to 3 positive lymph nodes with high-risk features, higher grades or higher Ki-67 scores. And we have found that they could be treated with 2 years of abemaciclib, which is a CDK4/6 inhibitor, a pill that we use a lot in metastatic breast cancer. So this has been moved up to something that we could use, or we do use, in adjuvant therapy for higher risk estrogen receptor positive breast cancer patients. So this was based on the Monarchy trial. And previously we just had disease-free survival benefit of about 3 years, but now we have 5 years of data that show ongoing disease-free survival benefit. They're still waiting on the overall survival benefit, but this is a good option, particularly for younger, healthier women that have higher risk disease, and we want to add something else to try to give them the best chance of this not coming back. The next trial, the NATALY study, is very similar to the one that we just talked about, but took hormone receptor positive breast cancer patients who were either stage 2 with N0 disease or had a high high Ki-67, a high oncotype DX score, or grade 3 disease, or had nodal involvement. And they were treated with ribociclib, so that's just a different CDK or 4/6 inhibitor, for 3 years. So the previous one was 2 years, this one's 3 years. And they found that there was about a 3% invasive disease-free survival benefit at 3 years. So not a huge number. But what was interesting about this study was that this is the first time it was looked at in N0 patients, so meaning patients with just larger tumors without any nodal involvement. So that's interesting. I think probably a little bit too early to say whether or not we can actually use this right now, but it is hopeful that this will also be eventually something we can use in the adjuvant setting for these patients. This next slide is talking about neoadjuvant treatment for triple-negative breast cancer. So I referred to this earlier. Generally, what most practitioners are using right now is this regimen that was tested with Keynote 522, and that is neoadjuvant chemotherapy with immunotherapy. So they would get that before surgery, and then that would be followed up with 1 year of immunotherapy afterward. And just some updates from this year show that there was a 5-year event-free survival benefit of about 9%. That's the absolute difference that favored the immunotherapy arm. And then there's a 5-year distance relapse-free survival with about an 8% benefit. We still don't have overall survival data yet. With a lot of oncology trials, it takes time to accrue that information, but this regimen's been adopted. We use it all the time, and we have seen really excellent results for a lot of patients, and we do see a lot of complete responses with patients going through surgery. And then moving on to HER2-positive breast cancer in the neoadjuvant adjuvant setting. This Catherine trial was something that came out a few years ago and changed how we look at breast cancer, and there were just some updates that continued to show really good success with this. And so the context of this trial is that typically we treat HER2-positive breast cancer patients with neoadjuvant chemotherapy plus targeted HER2 therapy, so with things like trastuzumab or pertuzumab, and then they go to surgery, and then they will often complete 1 full year of HER2-directed therapy after the surgery. The space where this trial sort of came in is, what about those patients who went to surgery after getting that treatment and still had disease detected in their lymph nodes or in their breast? Those patients were felt to be a little bit more high risk and have a higher chance of the cancer coming back. And so they switched them to this antibody drug conjugate called TDM1 and finished a year of treatment with that. And so that's kind of what this survival data is looking at. And it showed that the invasive disease-free survival was 32.2%. With TDM1 versus about 20% with trastuzumab alone. So that's a significant benefit, and that sustained at 8 years. And then we are many years out from the initial onset of the trial, so we also have survival benefit of about 4.7% at 7 years. So this is the standard of care now. If there is residual disease after surgery, we transition them to TDM1, which is just a targeted HER2 antibody drug conjugate. So taking a little bit of a break from chemotherapy, I wanted to talk about survivorships. There's a couple trials here that I thought were really interesting in the last year that helped talk about survivorship. And I think this is something that a lot of oncologists, we overlook, and we focus a lot about treating the cancer and monitoring for cancer recurrence. But I think we also have to think about life after, what happens to our patients, how they deal with this. This is just the NCCN guidelines standards for survivorship care, and I'm not going to go through all this, but the couple that wanted to draw our attention to is obviously number one, which is surveilling for cancer recurrence, which is something that oncologists, I think, are doing a good job of. But the next couple, monitoring for long-term effects, including psychosocial, physical, and immunologic effects, as well as prevention and detection of late effects of cancer and therapy, are ones that we have a lot more room to grow and a lot more research that could help our patients live better lives after we've treated them for their cancer. So one such study is this Be Well trial. And we do know, especially in estrogen receptor positive breast cancer or hormone responsive breast cancers, that one of the biggest advantages a patient can give themselves after is weight loss, particularly in postmenopausal women. If they are able to lose weight, they have a decreased chance of their cancer coming back, and that is important, and we know that. So this trial tried to formalize it a little bit. They presented at ASCO last year, and it enrolled overweight patients with a history of stage 2 to 3 breast cancer into a very formalized and structured health education and weight loss program. And on average, these patients over the year lost about 8 pounds and were able to maintain that weight loss. So this was really interesting. What they didn't do is, I would have liked to see, is translated into sort of a, well, how did they do in terms of breast cancer? But that certainly would be a much longer trial. But this may eventually become the standard if we can kind of have these programs available widely to help our patients lose weight and live healthier lives, because again, we know that this helps their risk of cancer coming back in the future as well. I thought this was one of the most interesting trials that came out last year. This one is about pregnancy and fertility after breast cancer. So breast cancer is the most common malignancy in women less than 40 years of age, with about 12,000 patients diagnosed every year. We do talk a lot about fertility preservation, and particularly in those patients that go on to chemotherapy, and that can happen through various methods, cryopreservation, and then subsequently IVF, or sometimes we just suppress ovarian function during chemotherapy with injections. But still, it is very difficult for these women to conceive after, for many reasons. One reason of which is everyone has a lot of anxiety about their cancer coming back, and particularly estrogen receptor positive breast cancers. We also advise against conceiving on certain meds like tamoxifen. And a lot of these women are on it for 5 to 10 years. So 5 to 10 years could be the difference between them being premenopausal and postmenopausal, so they don't really often have the time to wait that long before they can try conceiving. So the positive trial aimed to explore the safety of just withdrawing their adjuvant endocrine therapy to allow for pregnancy in these women. So they took women with a history of stage 1 to 3 breast cancer and were younger than the age of 42. And you had to have received at least 1.5 years and up to 30 months of adjuvant endocrine therapy. So they didn't want to take you off right away, but they were allowing for it after 1.5 years. And they took patients off for a maximum of 2 years to allow for pregnancy in these patients. And then I think after 1 year, they recommended that if they had not conceived, they see a fertility specialist. So these are the graphs looking at breast cancer events and distant recurrences, and they're actually fairly similar. So the bottom graphs right here, I don't know if you can see my mouse, are the zoomed out views, and then these are the zoomed in views over here. But essentially you can see that the cumulative incidence of breast cancer events was very similar amongst the patients, and similarly in terms of distant recurrence risk, you can actually see that the treatment intervention group was a little bit better than the control cohort, but ultimately this aimed to show that there was not inferiority to doing that. And so these patients were able to successfully come off and conceive and have children without an increased risk of their breast cancer coming back, which I think is really important. This was published in the New England Journal of Medicine, so it's a strong trial, and I think offers a lot of our younger patients some information that would be very helpful. Okay, and then moving on to metastatic breast cancer. This is where we're going to spend the rest of our talk today. And we're going to start off in the hormone receptor positive space, which is where I think most of our updates are for this talk. So context for this, we have the NCCN guidelines here, and I think kind of blurry, but they really review what treatment options we have for patients who have metastatic hormone receptor positive breast cancer. And over here on the left is where the preferred therapies are. And this is what we often will give our patients first line. So it's generally a combination of an aromatase inhibitor like anastrozole or letrozole with a CDK4/6 inhibitor, of which there are 3 main ones: ribociclib, abemaciclib, and palbociclib. We can also use fulvestrant instead, which is an estrogen receptor downregulator with those drugs. And subsequently, we tend to target therapy or can use everolimus exemestane. This is other recommended regimens and generally are just single agent treatments for patients that might not be able to tolerate multiple different options of management. So the SONIA trial was something that they presented at San Antonio this year, and was an interesting trial. It's kind of unusual in what they were trying to evaluate. But basically, they tried to ask, do all patients need those CDK4/6 inhibitors? So like the abemaciclib, ribociclib, palbociclib, do they need those first line when they have metastatic estrogen receptor and progesterone receptor positive breast cancer? So they had 2 groups of patients. They took one group and they put them on the standard therapy of endocrine therapy with CDK4/6 inhibitor. And then when they progressed, they transitioned them to fulvestrant, which is that estrogen receptor downregulator shot. And then they compared it to another group of people where they were given just adjuvant endocrine therapy alone, followed by fulvestrant with the CDK4/6 inhibitor. So in terms of the first point of progression, we definitely see that the endocrine therapy plus the CDK4/6 inhibitor, so we're better. And that makes sense. Anytime you have 2 drugs and you compare it to one, the 2 drugs is generally better. But what was really interesting is when they switched those patients and then followed them moving forward, they didn't see a difference in terms of their second progression-free survival, meaning those patients who got put on a CDK4/6 inhibitor did just as well as those patients that were just switched to fulvestrant. So what this suggests is that you could delay the start of the CDK4/6 inhibitor if needed. Still should be given up front, but we don't, as long as they get it first or second line, you probably haven't lost a ton of ground with this. Now the next few slides are going to talk about mostly second line treatment. So what we do after these patients have progressed on ribociclib, or palbociclib, and I'm blanking on the third one, but the current standard is use of alpelisib and fulvestrant versus capivasertib or fulvestrant. But this trial was an interesting trial. It was the INAVO 120 trial that was presented at San Antonio Breast Conference. And what this did was aim to be a little bit more aggressive. So they took higher risk patients, so patients that progressed within 1 year of coming off of their adjuvant treatment. So patients who probably had more aggressive disease or faster growing disease, and then they put them on the standard treatment, which is the CDK4/6 inhibitor and endocrine therapy, and then added in capivasertib as well. So now they're on 3 drugs here. So we can see the progression-free survival was pretty impressive at 46.2% at 18 months. Versus 21% in the standard of care arm, which was the CDK4/6 inhibitor. And the overall survival was almost 74% at 18 months compared to 67% at 18 months as well. So I mentioned earlier, anytime you add an extra drug, you're usually going to see a benefit, but you're also going to see more adverse effects. So you're going to see stomatitis, diarrhea, rash increased in these patients. So it's probably a tough regimen to tolerate for a lot of patients, but in the right person, I think someone who's young and can manage it, it could be of benefit. So just an interesting trial about that. Last year, I mentioned something about ESR1. So hormone receptor positive breast cancer patients who have an ESR1 mutation are often a little bit more resistant to typical adjuvant endocrine therapy. So the EMERALD trial took a look at using elacetrant, which is a different drug in these patients who have had a couple lines of therapy as well. And they published their results in the Journal of Clinical Oncology over here on the right, and it's a little blurry. But this first top graph over here is looking at the progression-free survival in the general population, so those without the mutation. And we can see that the progression-free survival at 6 months was 34%. Versus 20% in the standard of care arms. And then at 12 months, it was 22% compared to 9% in the standard of care arm. So there was a benefit even in the general population, but where you can really see the benefit is in this bottom graph. And these are the patients who had an ESR1 mutation, and their 6-month progression-free survival was 40 months. 6-month progression-free survival was 40%. Compared to the standard of care arm, which was 19%. And then that similar benefit was seen in the 12-month progression-free survival. So this was approved and is something that is now available for patients who have progressed on 1 to 2 lines of endocrine therapy and have this ESR1 mutation over here. Another mutation that had some had a trial published earlier this year was this AKT alteration over here. So this is, again, a similar population of patient who had hormone receptor positive breast cancer, progressed on 1 to 2 lines of treatment, and then had an AKT alteration. It's the Patel 291 trial. And again, over here, this is the overall population who was given this drug. And there was a slight benefit there, but the significant benefit that was seen in the patients who had these AKT altered tumors. So this ultimately led to the approval of this drug in patients who have AKT alterations. Their adverse effects were typically diarrhea and rash, and that's often what we see with these with this category of drugs. So moving on to HER2 positive metastatic breast cancer. This is, again, the NCCN guidelines for where we're at right now with treating these patients. And in the first line, we often treat these patients with pertuzumab, trastuzumab, and docetaxel or another chemotherapy. That's standard of care. Second line over here, we treat them with another antibody drug conjugate, trastuzumab deruxtecan. Third line is where we have a couple different options. One option is tucatinib, which is a small molecule inhibitor. It's a pill. with trastuzumab, and then capecitabine, which is a chemotherapy. And then TDM1, which is another antibody drug conjugate. We talked about that earlier with the Catherine trial, but it is also used in the metastatic setting as well. And then fourth line and beyond is sort of, you can choose what you want. There's really no guideline directed saying that this is better than this at this moment. So there's just a list of different options there. So the HER2, so an interesting trial that kind of bounces off of that is this HER2 CLIMB-02 trial. And that took a look at metastatic breast cancer patients who had progressed on upfront therapy and then were given TDM1 plus tucatinib. So if I go back, they combined this drug right here, this TDM1, with tucatinib over here. So they're trying to combine both of those regimens together to see if that provided a benefit, and it did. The median time to progression was about 9.5 months in the intervention arm and 7.4 in the placebo arm. What was really interesting and of note is that those patients with brain metastases also saw an advantage, with median time to progression being 7.8 months versus 5.7 months. This isn't yet approved in combination, but it is promising. The reason that tucatinib, or we're seeing this benefit in patients with brain metastases, is that tucatinib does have some CNS penetration and so is often used in patients who have brain metastatic disease. And then our last category is triple negative or hormone refractory breast cancer patients. So this is the standard of care right now, and the first line therapy is basically chemotherapy, and sometimes we can add in a PD-L1 inhibitor if they have the CPS score for it. And then second line therapy is really geared towards any germline mutations you might have, or the addition of sacituzumab govitecan, which is, again, another antibody drug conjugate, which we're going to talk about for a second here. So antibody drug conjugates, I've been saying that a lot. It really is just an antibody targeted to something with usually a chemotherapy payload attached to it. So it's directed and goes to where it's needed and minimizes toxicity of just generalized chemo, which just goes everywhere. So a couple trials here to take note of. Destiny Breast 04 was presented at ESMO earlier this year, and this took a look at patients who were HER2 low. So the drug in question is trastuzumab deruxtecan. So this is something we obviously know works in HER2 positive breast cancer patients, but this was then studied in patients who had HER2 low disease. And we could see that there was a significant benefit. Their overall survival was almost 23 months in the treatment arm versus 17 months in the physician's choice arm, which was most likely just chemotherapy. With a median progression-free survival of about 8.8 months in the treatment arm. So this is something that we do use a lot now and is reflected in the guidelines right here as a potential second-line option. The TROPiCS-02 trial over here is taking a look at sacituzumab govitecan in hormone receptor-positive breast cancer patients, and also can be used in triple-negative breast cancer patients. We saw an overall survival benefit of about 14.5 months versus 11 months in the control arm. And it's, again, a lot of these drugs, the reason we like to use them is because they just tend to be less toxic than chemotherapy alone. And so this offers another non-chemotherapy benefit. And then this last trial is actually not anything approved yet, but it's just another antibody drug conjugate that was presented at ESMO, and it's the Dato-DXd, and that showed about a median progression-free survival of about 7 months compared to 5 months with just chemotherapy, and the overall survival data is still pending. So this is still pretty early. And then the last one we're going to talk about is, I just thought it was an interesting trial here. We barely talk about the data behind using chemotherapy because that's been around for a really long time. We know kind of what chemos work and what don't. But this was a trial on how we deliver chemo. So capecitabine is a pill that we use very commonly in breast cancer and a lot of other cancers. So this was the X7/7 trial that was presented at ASCO. And it took a look at capecitabine and the dosing schedule. So we typically will give it 14 days on and 7 days off. It's a particularly difficult chemo to be on the longer you're on it. You have a lot of hand-foot syndrome, a lot of diarrhea. So this took a look at alternate schedules of dosing, so 7 days on and 7 days off. And there was less toxicity observed, I think, pretty significantly. We often see a lot of discontinuation in this. So about 30% in the 14 7-day arm stopped, but 7.5% discontinued in the 7/7 arm. So more patients were able to stay on this treatment. There was twice the amount of grade 2 to 4 toxicity in the 14 days on and 7-day on off or 7-day off arm. But obviously what matters is, was it effective? And this trial said, yeah, it was. Overall survival was 21 months in the 7 and 7 arm and 19.6 months in the 14/7 arm. So this just offers another opportunity to maybe give this drug, but with a slightly adjusted dosing schedule to help with tolerability and help with toxicity, which is big because if a patient can't stay on the drug, it's not super helpful. But if they can stay on it for longer and it works, then I think it provides us a lot of benefit. All right, last slide. So just future directions, and I think a lot of the themes I tried to point out while we were talking, but one is minimizing surgery when we're able to, particularly axillary dissection. So more trials are going to be geared towards looking at what happens when you get a really good response from neoadjuvant treatment. Can we change surgery and maybe radiation after that? We are trying to move away from chemo as much as possible. That means there's an increasing role for immunotherapy, and that means that there's going to be a lot more antibody drug conjugates and less single-agent chemotherapy used in this setting. And then lastly, the question that arises is the more treatment options you have, the more questions arise as to, well, how do you sequence them? How do you transition between that? So I think a lot of the trials coming up are going to look at that. With that said, thanks for your time, and I'll take any questions. I don't know if I know how to see if anything's online. Okay.
I'm not seeing any questions online.
Okay. All right. Well, thank you.
This is good.